Hello, and welcome to another episode of Perspectives from the Informed Perspective. We're Penny and Jenny, and if this is your first time tuning in, welcome. We're really glad you're here. This podcast is a space where we explore what it means to build strong, thoughtful communities grounded in our local lives, but enriched by the diverse connections, energy, and perspectives we gather from around the world. As our name suggests, we believe meaningful change begins by listening, really listening to different voices, lived experiences, and perspectives that might challenge or expand our own. Each episode, we take a closer look at individual stories that spark reflection and help us rethink how we understand community, purpose, and impact. Our podcast conversations bring together voices from around the globe, but the issues we explore are often grounded in the everyday realities of local communities, ours and others. These diverse perspectives offer fresh insights, build empathy, and ultimately bring renewed value back to the local contexts we care about the most. Following hot on the trail of our patient advocacy podcast from earlier this summer, today we turn our attention to the first of two conversations where we consider the perspective of physicians and doctors. Where do they stand in the wider advocacy conversation? How do they feel about patient advocacy and the demands and the needs of the public? Do they feel their voices are being heard, and are their own needs being met? As always, we want to encourage people to consider issues from every angle and perspective. Only by exploring different viewpoints can we foster greater empathy and understanding, helping us make more informed decisions in life. We shouldn't shy away from uncomfortable conversations or opinions different from our own, but rather embrace the complexity of human perspectives and the richness they bring to our understanding. For my own part, I approach this conversation from the perspective of a patient, and it's easy to understand the expectations we all have when it comes to accessing good healthcare and receiving adequate support. No matter where in the world, health services and systems are under pressure, and the traditional status that doctors once held has shifted. Patients today often have a greater sense of entitlement and expect more personalized, responsive care. At the same time, doctors are grappling with tighter budgets, mounting administrative demands, and a profession that no longer carries the same appeal, perhaps, that it once did. Are young people still inspired to enter the medical field, or are we seeing a shift in how their profession is perceived? If the spark is fading, what needs to change to make medicine feel like a viable, rewarding path again? And are there particular gaps emerging, roles or specialities that people are now reluctant to step into? What kind of support are doctors receiving, and what challenges are they facing, both professionally and personally? Is their work being recognized, and do they feel comfortable in a world where putting yourself out there on social media is becoming increasingly the norm? Before we dive in, as ever, we have a few quotes to get us rolling. Some quotes attributed to Hippocrates about medicine. To cure sometimes, to relieve often, to comfort always. And the life so short, the craft so long to learn. William Osler, a Canadian physician, said, "The good physician treats the disease. The great physician treats the patient who has the disease." Dr. Abraham Verghese, interviewed in 2010, a physician and author, stated, "My desire to be a physician had a lot to do with that sense of medicine as a ministry of healing, not just a science, and not even just a science and an art, but also a calling, also a ministry." And another quote from Abraham, but this time in his book, Cutting for Stone. "We come unbidden into this life, and if we are lucky, we find a purpose beyond starvation, misery, and early death, which was to become a physician. My intent wasn't to save the world as much to heal myself, but it can also deepen the wound." Dean Mafako, author, physician, and clinical professor of pediatrics, in his book Burnt Out, wrote, "The reality is that the lives of the smallest patients are in our hands, and their clinical condition can change in an instant. No matter how many times you are involved in situations such as this, the physical stress and anxiety, as well as the emotional and psychological effects of being immersed in that environment, are dramatic and lasting on the human body, mind, and central nervous system. These effects are severe, and I firmly believe that they are cumulative over your lifetime." Dr. Rahul Gupta, National Drug Control Policy Director, in an interview said, As a practicing physician, I come at this from the perspective of looking at the individual. We've got to have policies, systems, programs. All of these have to be designed around the people we're trying to serve. And Dr. Atul Gawande, surgeon and author, wrote in his book, Complications, A Surgeon's Notes on an Imperfect Science, "We look for medicine to be an orderly field of knowledge and procedure, but it is not. It is an imperfect science, an enterprise of constantly changing knowledge, uncertain information, fallible individuals, and at the same time, lives on the line. There is a science in what we do, yes, but also habit, intuition, and sometimes plain old guessing. The gap between what we know and what we aim for persists, and this gap complicates everything we do." And to conclude, a quote from E.B. White in her novel Charlotte's Web, uttered by Dr. Dorian, the family physician. "I'm a doctor. Doctors are supposed to understand everything. But I don't understand everything, and I don't intend to let it worry me." So now I move over to Jenny to introduce the guests today.
Thank you, Penny. And yeah, very excited that we're doing the other side of the coin following our patient advocacy podcast. And this is the first, as you mentioned, of 2 conversations. So as always, we'll probably skim the surface of these important topics, but I can't wait to get started today. So to first up introduce Dr. Dhaval Desai as a physician, author and patient advocate dedicated to human-centered, compassionate healthcare. Having served on the front lines during the COVID-19 pandemic, he has a rare mix of clinical insight and emotional honesty to the complex challenges facing both patients and healthcare professionals today. He is an author of Burning Out on the COVID front lines, a powerful memoir that sheds light on the unseen emotional toll of the pandemic. Through his writing and speaking, Dr. Desai calls attention to deep-rooted issues within the healthcare system, including healthcare inequality, racial injustice, the prioritization of metrics over compassion, and the alarming rates of burnout and suicide among healthcare professionals. In both his clinical work and public advocacy, Dr. Desai continues to champion the kind of care that sees the whole person, whether that person is the patient or the provider. And Jamie Gross is an NHS consultant and founder of startup company Medics in Control. Following his own recovery from burnout, Jamie noticed how certain themes of his own burnout story are common to doctors and other healthcare professionals. Leveraging his journey and experience, he is now on a mission to lead doctors towards better lives. Next month, he is launching a transformational group coaching program that leads doctors to reconnect with their purpose, reclaim a healthier work-life balance, and ultimately lead a more fulfilled life without retraining, quitting medicine, or taking on more work. His vision is to play a significant role in transforming the NHS by transforming the staff within. And back over to you, Penny, to start this amazing conversation.
Yeah, so thank you both for joining us today. I'd like to go to you, Jamie, first of all. We've spoken before about the fact that you had burnout in 2022, and that was actually a catalyst for you in your shift in your career direction. Could you tell us a little bit more about what that period was like for you and what led you to the point where you felt that you couldn't safely, and I think that you said that to me actually in quotes, that you couldn't safely care for patients anymore. I'd love to hear more about that.
Yeah, thank you, Penny. And thank you very much for the introduction. Really great introduction. There's so much to think about, so many things to untangle. I think in relation to your question, it might be better actually to start off where things started to unravel. Is that okay with you?
Yes, magic.
Yeah, fantastic. So I see the start of the whole burnout and the stress really after I became a consultant. So this is when I've been fully trained and in that consultant role. So up to when I was a trainee, when I was a training doctor, there was a lot of hoops to jump through. It was a tough training process, having to go through lots of night shifts and lots of exams and very intense medical training, having to sacrifice a lot. And a lot of people would think at that point, well, that's probably the toughest part of the whole medical career. but it wasn't that which actually was the undoing of me when I was burnt out. So at that point, you're working towards this goal, and the ultimate goal is to become that consultant. And I don't know what it's like in the US. I'm sure Dhaval will explain more. But in the NHS, when you become a consultant, largely you're taking a post on which you have for the rest of your career. So this could be a post where you've got for the best part of 25, 30 years. So you got that stability, and you got that job security. So everything up to that point was working towards that. Yes, it was tough, but I got through that. What I noticed, however, is that, and when things started to really unravel, was after I became a consultant. So you have 1 or 2 years of transitioning into that consultant role. And then I recognized about 3 years into that. So got the consultant job, really delighted with securing that post. And then a few years into it, I thought to myself, okay, well, I've got that role now. Things had changed from when I was training. So for the first part, you'll get a lot more exposure to the bureaucracy of organizations and the politics and things that you would largely be protected as a training doctor. But you get exposed to that when you become a consultant. So that's the first thing. The second thing is when you're training, you're growing. Okay, you're growing into that consultant role. When you've reached that consultant role, well, what's next? So this is kind of what I was always thinking, because I always love growing and aspiring to be the best I can. And then the traditional roles that are available to medics, specifically in the UK, I don't know if it's the same in the US, it probably is research, which I wasn't really that interested in, or medical education, which I see a consultant role as educating anyway, but I wasn't really interested in a formal medical education role, or hospital management, which is full of bureaucracy and politics, and some of things can be quite toxic when it comes to the politics that you have to deal with. Particularly when you spoke about at the top of the conversation how often you're working within a resource limited environment and a highly bureaucratic organization. It's very difficult sometimes to adjust to that. So the career side of things was two things. Number one, I didn't feel like I was growing. I felt I was stagnating. The second thing was that there was exposure to the bureaucracy, the high admin burden. I came into medicine really to practice medicine and to make a difference with medicine. The admin side, the bureaucracy side, all I saw is just layers and layers of stuff which is getting in the way from doing what I actually really was passionate about, or really what I wanted to do, which is basically to make a difference to patients. And that in itself in the role was quite difficult. So I ended up doing a master's degree in palliative care, because I'm an intensive care consultant. There is a overlap with end of life care. And that was kind of the default, which I was trying to do just to grow, which we can talk about. But it wasn't just the career circumstances. There were other things going on. So when I became a consultant, I became a parent for the first time, got married a few years before, became parents for the first time. No one teaches you to be a parent. All of a sudden you've got that parent responsibility. We started a family when I became a consultant. We recognized a few years into our son being born that he was a bit different to most other kids. It transpired that he was diagnosed with ADHD age 6, and that was in 2020. And parenting I found very challenging. We had our second daughter come along in 2018, and then all of a sudden the house that we were living in was listen, it was manageable, but it was a little bit tight, and we decided to upsize house. I have no idea about finances and wealth creation and investments. So I upsized house, took on a huge mortgage. And then I thought to myself, well, I'm at the top of my pay scale here. How am I going to pay that back? And so therefore I thought, well, the only way I can pay it back, this big mortgage I've taken out, is just to work more. So then all of a sudden I thought, well, okay, well, I'm at the top of my pay scale. If I work harder, I can do extra private work. I can do some extra NHS work. But then the work-life balance started to come into play as well. And I was working harder and harder and longer not having the time at home. I found looking after two kids, one with ADHD who was addicted to screens at that time, really, really challenging. The career felt stagnated. There was a lot of bureaucracy and exposure to the NHS politics at that time as well. And then really at that point, it's interesting because at the pandemic was when I started to take up running as a hobby, and I found it a really great release. But as it happened in 2022, I got injured. I was training for a sub 3 hour marathon time. I overdid it basically, and I got injured. And then when all the wheels completely fell off is when we decided to exchange on that bigger house. The house was a new build, and I had to live somewhere, and we chose to live with the in-laws. And I know the expressions on your face, and it unfortunately just didn't work. I was living under someone else's rules. The career was stagnated. Not toxic, bureaucratic organization and politics, and being disconnected from purpose, not able to run, challenging parenting. Got to the point where I was really, really sort of not in a great place, really angry, really frustrated with certain situations. I did play a bit of a victim card at that point, to be honest with you, but then that started to affect the relationship I had with my wife. And everything just came into a head, basically. So a long-winded answer to a question, but it was a build-up for quite a few years.
Yeah, and I mean, I'd be curious to know, was there any kind of support offered at all within, the medical field, from your colleagues, from the people around you? Was there anything that you were able to get access to? Was it something you weren't aware of, or is it something
Yeah,
you identified within yourself?
it was really interesting because I wasn't actually aware that I was burnt out until I was actually burnt out, right? So the first thing is that people, unfortunately, and I don't know whether this is the same in the US, but people very much, when they're at work, they talk about work. It's kind of not really, I don't know whether people are too busy or there's too much dissatisfaction amongst the medical workforce, but a lot of people don't really bring their personal lives into the workplace, and it wasn't just the career side of things. I mean, funny enough, actually, if I was to say that I was a bit dissatisfied with the various career, there's no career advice because of the appraisal process that we have to go in now is very much more of a tick box exercise than it used to be. Very much, have you done your CPD points? Have you got the right amount of patient feedback? Have you got the right amount of staff feedback? And that all conforms into an appraisal process which is mandated by the General Medical Council, which is our regulator. But there's not really, as part of that process, not really anything saying, "Oh, you're right. How's it going for you?" There's very much a tick, 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 tick. Yes, you're okay to go ahead. So I didn't really feel that I could honestly open up at work about some of the challenges I was facing within work. In terms of everything else going on, yes, my marriage was kind of struggling a bit a few years before that. We did go to see like a marriage counselor or a marriage advisor. That helped a little bit on a temporary basis. That was one thing. The finance things I had no idea about. But you know what? A lot of people that I spoke to, some friends, for example, that I confided in, often, and some family members as well, often the response was very much, well, basically, that's part of life. Just get on with it. It's the same for all of us. So I felt that the actual official support structures at work, I didn't really tap into. We can talk about what happened when I was burnt out, because in the lead up to that, I didn't really feel that anything was valuable to me at that point. There are other support services like marriage guidance and things like that, which we kind of tapped into. But I was really very much fighting in this.
You didn't speak to any colleagues at all about it and sort of say how, same thing showing up for you or anything like that?
You know what? I didn't actually. And it's maybe, I don't know why that was the case. Maybe it was because people just don't open up at work and people very much in their roles and they talk about work-related stuff. There was one colleague I spoke to about the finances, and it was very much a case of like, oh, I've just taken out a massive mortgage here. I've got no idea how to pay it back. I'm going to be working literally until God knows how long, 75, 80 years old. I've got no plan of how to pay it back. And he said, why are you doing that for? Why are you working so hard? Actually, if you continue to do that, what you're doing, first of all, you're not going to be around for your family. And secondly, you're never going to escape the rat race. And then he introduced me to the idea and the concept of wealth creation and making money work harder for you. He introduced me to two books. One was Rich Dad, Poor Dad by Robert Kiyosaki, and the other one was T. Harv Eker's Secrets of a Millionaire Mind. And that really sort of introduced the concept of wealth creation, passive income, the difference between assets and liabilities, and how to start growing your wealth. Because one of the things I recognize, and one of the reasons looking back at why I might have done medicine, is actually I saw it as a place of financial security and financial stability. Now, I'm not saying doctors are poor, because we're definitely not. But when you go through 15 years plus of medical training and the lifestyle that you're living may not be in keeping with what you thought that lifestyle might look like, and you're still trying to live and aspire to that lifestyle, rightly or wrongly, it's very easy for colleagues, and myself included, to get into that trap of just working harder and longer and then losing sight of what the most important things are, which is basically, number one, your health, number two, your family, and number three, probably your purpose and passion.
And I also think it's so interesting to hear you speak, Jamie, because it's a profession where the work is deemed hard. You know, it is hard work. It is full on. You go and you kind of, you know, excuse the cliche, but put your uniform on and you're in your professional capacity, you know, and I can completely see how it's hard to open up from a personal point of view. And Dhaval, I know in your intros it mentioned that emotional honesty as well, and to have that strength and ability in those, you know, types of professions, you know, where it's like you've got a serious job to do. It's fully, you really need to concentrate. You know, with all due respect, I've come from a corporate background, you know, in front of computers. I can take you know, some time off, not as in, you know, 10 minutes and talk to someone and have a catch up, and it's not always the case in you know, this, it's full on, and when your shift's on, it's, you know, you're on and you're at it. And I think it's really important to hear how there isn't a space for that emotional,
And
personal stories or experiences.
Yeah, and do you know what I've recognized, 'cause I've gone through the other side and I've gone through loads of personal development training. I think that's a real missed opportunity, actually, because I think that a lot of people are really struggling within themselves. And there doesn't seem to be enough in the way of it's okay to talk honestly and openly and authentically. And actually, I did a really powerful training program just over a year ago, and I recognized the importance of being vulnerable and just being honest with people, and how that gives people the invitation to open up freely to themselves. And the number of people that, and it's funny because since I've done that training and since I have been more vulnerable, I have been more open in the workplace, and I'm not asking for people to open up themselves, but people just do because they feel that they're safe. There's some sort of layer of safety and security, that they're not going to be judged, and they can share openly. And that's the first start, I think, to overcoming a lot of stress that's pent up amongst healthcare professionals.
I would agree with that. Yeah, I would agree with that, Jamie. You know, first of all, I love all of that. Everything you said rang a bell with me. Like everything. I'll share my perspective a little bit just in parallel, but to pick up right where Jamie left off there, you know, you have to be vulnerable in order for other people to relate to you. But bigger thing is you need a leader that's willing to be vulnerable and willing to set the stage that it is okay to not be okay, and you can still be highly functional and not okay. And countless times in medicine, especially as physicians, if not the majority of time, we are not in a mix of leaders that do that. I think the pendulum is slowly swinging, but when you ask ourselves in the US, guys, the suicide rate for physicians is 400 physicians in the US die by suicide every year. That's more than one a day. It's appalling. It's appalling. You know, to parallel what Jamie said. I think in medicine, pre-med, going through from high school to college to medical school, the whole journey, the years it takes, we're all promised something that's not what it turns out to be. You keep going and going. Well, okay, I'm going to be a medical student, then I'm going to be a resident. We call it a resident. Then, okay, I want to specialize and be an intensivist, whatever. You're going to go get your fellowship. Then all of a sudden we call an attending, where you're officially in that role. And then what? To your point, Jamie, exactly. Then what, right? And that's classically, chronologically, the time where the majority of us are settling down, starting families. We're in this age group of 32 to 40, and everything is changing in our lives. Everything you said is parallel to what I have gone through as well. And I think mine goes a little deeper. That first year after having our daughter is now 10. Oh my gosh, that was so hard. And I'm trained in pediatrics, and that was still hard, and if not harder. I'm serious. I know what it's supposed to be like. And I was like, I can't do this. And the turmoil you have at home, the chaos, the stress, the tensions, and you go up to the hospital. And I always say you're giving it all at the hospital, but then you don't have enough left to give at home. And that's when we need to be giving the most. And I realized that the very hard way. And the term burnout is technically an occupational hazard, where if you are removed from the occupation, i.e. 2-week vacation in Greece and just frolicking, you should feel better. For me, that was not the case. I did not feel better after being removed or taking a week off. Yeah, I felt relaxed. I'm like, okay, but I knew in the back of my mind all those thoughts of what's next, what I have to do, what project's pending. Ooh, I should click on the mailbox on my phone to check the email. I should see what's going on. All of that's still there. And so many physicians in the United States especially do not want to admit that they have some type of mood disorder or mental health challenge, because of fear of retribution, that this will impact their credentialing, their licensure, their ability to practice, which will then impact their ability to make money and support our mortgage payment. How are we going to do that? And I'm going to give a plug. I'm an ambassador for the Dr. Lorna Breen Heroes Foundation. Dr. Breen was a physician, an ER physician, who died from suicide in 2020 while working in the trenches in New York City. And I share that story because the family has done an amazing job setting up this foundation, trying to change the culture, and they are very successful. And again, I'm an ambassador. I will gladly share this article with you after this podcast, but there's a New York Times article published in the summer of 2020 about Dr. Breen's life and story. And I kid you not, every time I have read that article, I have a visceral reaction and I clench up. And the reason is that could have been any one of us. So there's so many parallels, and as refreshing is not the right word, but refreshing as it is, Jamie, it's fascinating to me that you go through the same thing despite a different system, the exact same situations that we do. And I think it comes down to, you're right. I love that you took a course on vulnerability, because I led my group of 30 physicians. It was a small unit, but I created that vulnerability intentionally. But as soon as I started sharing my issues, they're like, you, out of all people, you can't have issues. Oh, you have no idea. We hide it. We all hide it. To your point, Jenny, you put your uniform on and you go hide it and you leave. And then what's after that? So it's a lot. And I don't think we're here to solve the issue, but at least talk about where the issue is, what's really going on. And I really commend you, Jamie, for in parallel doing what you're doing and taking care of yourselves. And I think you're right, that running, getting your heart rate up, that's phenomenal. But that went away, and that created, your outlet. Your outlet went away then, right?
Isn't it that balance as well, that
yes,
that you have something outside your work, outside the job, something else that defines you, that gives you another meaning, also additionally to the family as well, right?
Yeah, doctors don't have a lot of hobbies, a lot of us.
No.
We're rather boring in many ways, right? So
it's time as well. And I also think it's important to point out, I made a statement on your profession and, some assumptions and whatever, but actually, you have got people's lives in your hands. You have the responsibility of human beings and their health. We talked about Dhaval taking time off and a holiday, or Jamie, when you mentioned you get to burnout, or when you're admitting that you're not strong enough mentally and probably physically by that point, you've got people depending on you, not just some, you know, and this isn't dismissing other professions, but, you know, it's not as easy like I need to take some time off and actually could just hand that over to, you know, someone else in the team to pick up the marketing campaign or the month end finances. You know, I'm making light of it, but I think it's really important as well to call that out, because you know, I can imagine you can't just say, you know, I'm not feeling up to it, and you know, I'm going to take some time out, because then people are going to have to know that you are strong enough mentally and physically to come back and help those people. It's a vicious circle.
Well, I'd like to add something, if that's all right, and that's very much relates to the culture of medicine, or the expectations that we think medicine puts on ourselves. Very much, I don't know if you've heard of this issue about the heroic doctor analogy, how almost, I think it's probably something which we've kind of led to believe over a while, how doctors have to go above and beyond what their expectations are. Like, for example, when I was training, how many times I stayed way beyond my going home time to make sure that things are okay. And it almost gets to a point where there's a bit of mission creep, where it's almost expected that you should go above and beyond what's expected of you. And then there's an issue about those boundaries, because what's really important, you mentioned about you not having time to engage in hobbies and things like that. Well, if you're working above and beyond because you feel that that's what everyone else is doing, and if I don't do that, then people are going to think less of me as a doctor. Maybe they're going to feel that I'm not as committed as certain other colleagues. That's when there's an issue, because that's when you get blurring of personal professional boundaries. And that was one of the other things which was unraveling for me.
And to that point, you know, the other piggyback a little bit on that, why is it so hard to do our job after we're out of the protected lens of being an educator, or, you know, in medical education, being an undergraduate, postgraduate, whatever? Why is it so hard?
We lost Dhaval. I mean, that sort of returns back as well as to, you know, how do you support the young then who are also coming into the medical profession to be prepared for that, Jamie? And I guess that's part of what you've also spoken about, wanting to transform the NHS from within. Is that sort of supporting people so they know what is coming up ahead, being better prepared?
Yeah, so I think one thing I'm trying to promote really is the fact that being a doctor just doesn't define who we are. It's not our complete identity. We're all people, okay, and we're all different, and we're all unique in our own right. And medicine is an important part of our career, but there are other things as well which are really important. So we've all got different passions, hobbies, and interests. So that's important. We've all got friends. We've all got families. We all also live in a society which is dictated by money. I'm going to bring the money in because it's one of the taboo subjects in medicine. But actually, money it means a lot of different things to a lot of people. But as far as I'm concerned, money is associated with choice and freedom to do what you want, when you want, and with who you want. So there's all and I think the difficulty is when people very much medicine becomes their life and there's nothing else going on. That's when there is a problem, because of those boundaries that we just talked about.
But we lost you for a minute there, Dhaval.
I'm back. I apologize. Sorry. I guess we're across oceans, so sometimes stuff will happen. We were talking about this. Yeah, I mean, I think the boundaries are key, and I find a lot of times we don't know how to set boundaries because we are trained to, number one, always do what's right and not make mistakes. And the system puts a lot of challenges for us to do the right thing for the patient and jump through so many more administrative hoops to do things that we do have to advocate constantly. And that's fundamental to our job. And I would not want any other way to be called but to call it an advocate. But does it really have to be that hard? And at what cost is it to us as the physicians when the advocacy to get certain things done for patients is so much, it outweighs anything else? And while it may sound a little exaggerated, it's that cumulative effect that we talked about of keep going and going, and you're promised a system that, you know, you're going to be a doctor to help people. Well, yes, but to help people, you have to fight through so many hoops to do that. And it's here in the United States, I'm going to speak transparently, it's getting harder. It's getting harder by the day. I don't know how it is there, if it's getting better, reinventing within NHS, Jamie and Jenny and Penny, but it is getting harder here. The motto of doing more with less is inherent to anything that we do.
But I was talking to a physician last week, sorry, Jamie, and he was mentioning, he was also from the US, but saying that actually the number of students wanting to study medicine is definitely not going down at all, but there are more expectations potentially now. That it has changed a bit, the discussion, that people are a bit more decisive about what field they might want to go into. And then you're getting these gaps where certain parts of medicine are no longer being covered, potentially ones that do traditionally need more overtime or more intensity or whatever, and people wanting to be more definite about the shifts that they're working because they also want to value their family. So you're getting that other side of the coin too, which is, yes, you want, you know, you want to have everyone to have a better standard of living and balance and all the rest of it, but at the same time, how do you work out that conundrum?
I think, you know, I always say, don't, to the medical students, residents, don't specialize for the wrong reason, right? If you're specializing for the sake of finances, which by history people specialize because they want to make perhaps more money than a generalist, fine. But if you end up specializing and end up doing it and end up not loving it and you're miserable, that's also very palpable. And nobody wins ultimately with that. And I think we know here, generally what we're seeing is primary care specialties typically are lesser in demand because of the nature of the beast, so to speak. And we're also starting to see some specialties not be as popular too. Nephrology being one of those that nobody's really, and not nobody, but the number of people deciding to go into it's far less.
That's a problem.
It's a challenge. It's a challenge. So how do we make it all attractive? I think it's not necessarily specialty dependent. The specialty may be suffering because the system fundamentally at the bottom of the pyramid is not serving the way it should.
Yeah. So tell us a little bit about you. So Dhaval, you've recently launched your direct primary care practice, and I'd love to hear a little bit more about that.
Yeah. So historically, the model of primary care in the United States is, you know, insurance-based. You use your insurance, you go get your annual physical, and you go for acute needs and perhaps get referred out for specialty issues. What I find, and what a lot of people are finding, it's few things. It's harder and harder to find a primary care physician, number one. Number two, it's harder to find somebody that's going to be able to handle and want to handle what you need to get handled. And to the credit of the primary care physicians doing this, 15 minutes is not enough time to do what you need to do and establish a good relationship. So the constant demands on that are very high. And I frankly don't want to spend 5 hours a day documenting. And that's what most of us do. Even as a hospitalist, I did that. And I turned into sort of a cash register for the insurance company because I have to document a certain way and certain things and certain buzzwords in order to get maximal reimbursement for the hospital, allotted length of stay for the patient. I mean, the list goes on and on. We could talk for hours about that. But none of that seemed for me to really add value to the patient. So the DPC model, or direct primary care, is a model where patients can still keep their insurance. So if they have a catastrophe, if they have a surgery, if they need a specialist or somebody, you know, something outside of my office, they can still use their insurance, but they pay an annual fee to be part of my services. And it's a fairly reasonable fee, but you have unlimited number of office visits, no copays, 24/7 urgent access for urgent issues, i.e. to avoid the ER, urgent care if we can. And the idea with this model is physicians can have a smaller patient panel, spend more time with the patients, get to know them, and actually really get to the root of the issue. And, you know, for us physicians, have a greater joy in practicing because you have meaningful relationships, you know your patients, you get an hour-long visit with them. And guess what? I don't have to document for the insurance company because I'm not charging the insurance. I get to document what's meaningful for me and the patient. And that's the exciting part of this. Truth be told, you always feel vulnerable. To Jamie's point, how am I going to support my family if I don't end up getting patients and all of that? It's certainly a risk. But what I'm rapidly seeing in the startup phases of this is that there is a demand for this, and there are people out there. And I went through the phases of saying, well, by doing this model, who am I leaving out? Is the indigent community being left out? Are patients who can't afford my fees being left out? And a few counter arguments to that is, well, I'm not charging an exorbitant amount of money. And there are those in other DPC physicians who I'm connected with who have self-pay patients who can actually afford this over paying for health insurance. And we can also set up, a little bit scholarships or what have you for patients that are really struggling, albeit to say there's ways to make this work for everybody. And I'm going to try it out, and I think it's going to go great. I'm really excited because ultimately, if I have to ask, well, what's going to keep me going in medicine and not want to pivot out of this field, I need somewhere where I can have meaningful relationships with patients without being dictated of what I can do, how I can do it, and when I can do it, and I'll still be an advocate for them, maybe even a stronger advocate now that I'll have time to do that and navigate them through the complex healthcare system.
Great. It sounds really exciting. And I think it's really important. I mean, from my own perspective as a patient as well, it's also thinking a bit more holistically, isn't it? So that if you have longer with that patient, you could potentially ask them other questions that you wouldn't normally be able to. So getting a bit more of those puzzle pieces and working out, what is the diet doing? What is the exercise doing? What is the home life doing? What is the stress doing? All of that, and I think that is sorely lacking also in Europe a lot. I mean, I had struggled with chronic pain in my leg, and I've been to so many different consultants and doctors, and no one ever found, and no one talked to each other. So I almost felt like, look, I have this situation, but it's not this. So can you all together sit together in a circle and talk about me? Because that would be my best situation. But I mean, of course, that's maybe a bit idealistic, but there is a level of actually, I'm a whole person. And actually, maybe there are different things going on, and there's anxiety coming in, and there's other things that might, be making those other triggers and other symptoms much more worse, right? So I think there's a lot to be said about that. I'm curious to know, for you, whether now that means for you, you're going to have to get yourself out there much more with your marketing and your social media presence. Is that a pressure that you feel, or not really? Is that making, I think that's, as a doctor, also a space where
a little bit, but,
right?
I love social media. So that's
okay. I have seen you there.
I say that, right? Little Instagram. No, I love, I think getting myself out there is going to be key. And also I'm practicing in a community where I also know the community. I know other physicians, I know specialists. And as I share where I'm going to be, what I'm doing, so many of them say, oh, we have patients looking for this, give us your card, we'll send them your way. Yes, the marketing aspect is there. What I don't want to be is a car salesman trying to sell them a service. That's not why I'm doing this. So the marketing, to your point, it's going to be done very tactfully, getting back to what I want to do and why I want to do it. And openly, the patients I met over coffee in the office just to kind of talk about if this is right, I said, tell them openly, there's no pressure. This is not the right model for everybody, and that's okay. So we have to be able to, have a mutual respect and understanding that I'm fine if it's not, but if it is, let's talk more. So that's a very meaningful and productive part of the conversation in marketing. There's no pressure to sell anybody anything.
But I think Jamie, go on.
No, I was going to say, first of all, with that amazing what you're doing, Dhaval, is brilliant. What occurs to me, and this is a common theme that I've noticed. Okay, so you're looking at it where you were before. I don't know what you're doing before. You had relative lack of autonomy. And also you were slightly disconnected from your purpose, because what you want to do really is you want to get to know the patients, you want to develop a good rapport and relationship with those patients and really make a difference to those lives.
Well, I was really, my initial purpose was going up in hospital administration leadership, and I didn't share that earlier, but I rapidly became the director of our group, led them through COVID, was at a relatively good director management position within this large healthcare system. But over the last 2 years, I realized that I can't lose my integrity if I were to go into something higher. And I could see that a lot of that happening. And I did not want to work getting back to the purpose. Like, it was not going to serve my purpose seeking out more roles. And this is not to say they were ready to give me anything either.
Yeah.
I think we realized that the thing, Jamie, is I didn't want to be a say yes person, and they
Right.
the bigger system likes yes people.
Right.
And that's where you start losing your integrity. It's like, no, I'm still on the front line with these. I know what's happening. I won't, So that's when I said, okay, you know what? It's time for a pivot. And I, believe it or not, I had to see an executive coach to coach me into leaving, because you feel so much pressure to do this and stay. What are people going to think? I've been this prominent leadership position in this prestigious academic institution. Why would you leave that? And I'll share openly in this podcast. This is a safe tree, and I love it. But
you're both doing that, aren't you? You're both taking.
I think so. But the coach said, no, your loyalty is what's holding you back. Your loyalty is holding you back, and at the end of the day, no one's going to really care if you move on. You'll be replaced, and that's the harsh truth.
Yeah, it is. I just want to add something. Just want to go back, right? Because what you're looking at, what it all boils down to, is that because you're working in an administration, NHS, call it NHS or call it whatever healthcare system. You're all of a sudden you're getting just stuck within all the bureaucracy and all the admin and all the things which are the reasons why you didn't do medicine. You didn't do medicine to do the admin. You didn't do medicine for the politics or everything else. You did medicine because you wanted to make a difference to patients. And this is what I see time and time again, is how so often you do medicine for a reason, but you start losing your purpose or becoming disconnected with your purpose, because all of the administration things, they start taking over. And then you start getting angry with it, and then you'll become less compassionate towards yourself, less compassionate towards other people. You can't deliver that compassionate care because you're so riled up and frustrated with the system. And the other thing is the autonomy side of things. So Dhaval, you've gone and you've set up this thing in primary care. You've set up your own service, your rules. You've got that degree of autonomy that you can tailor it how you like to. You mentioned about social media campaigns, and it doesn't matter. You can actually put your own stamp on it. You've got that control. You've got a vision of what you want to achieve, what you want to create, what's important to you, and you can actually follow that vision. Now, if you're working within I can only really speak for the NHS because that's where I'm working, but you don't have that autonomy. If you've got an idea about
working for somebody, you don't.
No, you don't, because if you're working for the NHS and you're saying, I've got a great idea about something, then what happens is you'll say, well, okay, fine, you've got a great idea about it. Well, we're going to have to go through these committee meetings to do it. So why don't you do a business plan? You do a business plan, you go to committee meetings, and all it takes is one person to say, no, you can't do it because either we've got other priorities or there's just no funding and you're just going to have to go back. I'm an intensive care consultant, and one of the things that I'm really passionate about is how to really help colleagues really navigate the end of life situation. So patients that are dying on the intensive care units, on ventilators, how their families are coming in, and I feel really sorry for these families because they've got the weight of the world on their shoulders. They've got this cloud of uncertainty. They've got different information from different people. It's a really difficult situation to navigate. I created a communication skills program. One of the things was to actually start just becoming more vulnerable and having that safe space that people could share, because people do get stressed with these conversations. The staff I'm talking about, not just the relatives. And the people that were involved, who the beneficiaries of that program they thought this is just the most amazing thing. This is great. When I go, I'm not blaming anyone, but when I go to the hospital administration and I say, this is what we're trying to do, this is what we've done so far, is very much, well, we can't consider it this year because it's not part of the remit for this year. We're too financially stressed. And then I think to myself, well, that's my free time. And if I'm not going to be able to get the support or the funding to actually give it a go and see what happens, then I'm potentially adding more stress to my plate because it's my own personal time. And actually, is this serving me, or is there a better way of doing things? And that's when I decided, you know what, this is not serving me. And actually, one of the reasons why where I founded my startup company, and when I put my energy into that is because I've got that autonomy. I can grow that exactly how I want to grow it,
It's your
and
baby. Yeah.
I'm not bound by other people telling me what I can and can't do. And I think those two things, the autonomy, the lack of autonomy, and the disconnection from purpose, because you've got admin and all these other things going on, which are one of the biggest drivers actually for burnout in medicine.
Absolutely. And for disconnection, most of us don't realize we're disconnected until it's too late, right? Where you're getting patient complaints, your performance is lacking, physicians go a slippery slope with substance abuse. There's a lot of issues, right? And then I think we're promised autonomy, as we think we're going to have once we get into the highest role that you're in, consultant, attending, whatever we want to call it. But we rapidly realize we're not. And Jamie, I can't tell you the number of ideas and projects we did over time. Same sort of thing. Committees, everyone's excited, great, great, great. And then all of a sudden chopped. And then you're doing it pro bono. And then physicians are like, well, I'm working a full clinical slate. I'm the director. I can't do more. And then you feel guilty for saying I can't do more, which you know is a value add. But then, you know, you're putting a lot on you, and you have to learning no is a complete sentence. Somebody told me that. And a lot of us, especially in that junior years when we're trying to establish ourselves, including myself, when I started, I had a hard time saying no. I got better at that, but I had a hard time saying no.
How might physicians be better included in shaping health policy then? Like, how do we move forward from where we're at? I mean, it's obviously, we're talking about the US and the UK, different systems, but how can they be
I think you always need the voice of the front line at the table when you're designing something or redesigning something. And what I fear is the physicians that are currently perhaps doing that, I don't know what it's like there, without getting political. We have a lot of hot topics going on these days here, but it is not people that are on the front line seeing and doing things every day. And I just don't see how we're going to get better from that without having that. And that's why I always, you know, as a leader, I always had to stay in the trenches and still work nights and do weekends and all of that, because I can't stand the idea, Jamie, of being detached from what it feels like to what our colleagues feel, right?
Yeah.
Especially when we're kind of, we should always be elbow to elbow. So,
how do you?
I would second what Dhaval said, and I would say that really what we're looking at is with two things. First of all, I completely agree with Dhaval. I think we need frontline people that really know what it's like on the front line to be able to lead that health service. Now, that's difficult, obviously, because the more of the managerial stuff you do, the less or the more potentially detached you get from the actual what's going on the front line. So we have to recognize that. The other thing I would say, and one of the best things that the NHS, or not just NHS, like across the globe when it comes to healthcare, is for leaders. I just really invite them, encourage them to really listen in. And when I say listen, I'm not talking about we've done an event and we can tick a box that we've listened to them. I'm talking about really get curious. Instead of actually almost dismissing clinicians saying, oh, they're just complaining about it. Actually say, okay, fine. You're not happy at the moment, and I can see you're not happy. Well, tell us what's going on for you and tell us how we can support you to try and make a difference. Now, it might well be that whatever the clinician's doing, there might be lack of funding, but it doesn't seem to be enough of that two-way communication process, the listening in from the leaders, but also that culture where you are free to be able to speak up freely and openly without the fear of repercussion or judgment from something. Because one of the things that I notice in myself is if I started to speak honestly and openly about something. Now, listen, I'm not, you know, blaming anyone, but I'm just saying that sometimes opinions and views can be seen as conflicting. Okay, and like, oh, Jamie, he's the, you know, the one that's making the trouble again and things like that. Well, actually, it's not what I'm trying to do. I'm just trying to do the best I can for the departments and the hospital and the patients and everything else. But when there is that bit of pushback, which you can happen, and I get the fact that everyone's under stress and under pressure, then very quickly do you start closing up and think, you know what, it's just not worth the energy to start saying that.
And that's the problem, though, right? Because you're going to lose your best and brightest, right?
Right.
That's the problem. When I left there, and this is not trying to boast me, but they're like, wow, they're losing one of the best advocates out there here. And I said,
absolutely. And if you compare it to business, now I know it's a bit of an overlap and a bit different, but the most successful businesses out there are the ones that really listen in to their staff, what's happening for their staff, what's happening for their clients or customers. They're the ones that are using that and then feeding that back in and then changing things, continually changing things, all based on that feedback. And one of the things that I think that can really make the biggest difference is that more sort of honesty, the openness, the listening in, and the curiosity of what's going on, and then just really trying to foster that collaborative relationship between the managers and the clinician. It seems to be that disconnect, and it seems to be that whatever's been tried, it doesn't, there's always it's managers versus clinicians.
Solution, no.
Yeah,
and you see people are getting anywhere with it. That's the example for other people to be like, yeah, I can now run with my idea, with my energy. It doesn't just stagnate, right?
Exactly. And hearing you both speak, like it's so inspiring. I can't think of a better word, but it's like you are innovators in what you are doing and how you're thinking, the approach you're taking, and the different routes you're taking. And that's because these healthcare systems are old and established, but that means it's so hard to change them. You talk about going to committees, there's the change processes, there's the systems, there's the infrastructure, it's at times, and most of the time, probably impossible, and that's why it becomes stagnated. But if there's, to Penny's point as well, that people need to hear about the work that you guys have been doing, to be inspired, to have, actually, that aligns with what I want to do. That's what I could look to establish. That's actually the help I need. Oh, I know someone that is showing these signs. Have they got these things under control? Have they lost their purpose? Are they struggling or, bogged down with personal finances? There's these so many people doing so much good work, but sadly the official organizations aren't able to showcase it necessarily. And, I hope in some trusts soon, one day, or if they already are, there are leaders that are able to open their mind and capacity and functionality to showcase some of this. But that's where I think it's so valuable, how you're talking, but also what you're both doing, because these systems are very hard to change, and it isn't necessarily possible, but there's lots of other amazing stuff
and you're dealing with all these personal emotions as well, aren't you? And that does feel like, in the media and stuff as well, it does feel a bit of a disconnect between patients and doctors as well. There's a lot of talk at the moment around vaccines, for instance. That's a big thing, and if you're a doctor, you're potentially the scientist. Well, hopefully you're the scientist, so you're being led by the science, but you've got patients coming in who are saying something else because they're hearing something else, or other things like the weight loss drugs, all kinds of things coming in. And also, I think expectations. I think I mentioned that in the intro, that I think there is that. I don't know if, from your own experience, the demands as well that are coming from to an extent are also totally, absolutely normal and expected. But, can you meet those expectations? And I think that is also
It's a lot. I think getting back to it, I'm an advocate that every physician should have a therapist to talk to and have some sort of ventilation. And I had to find therapists. It took me one or two to find the right one. And I have to share this. I learned this at one of those wellness conferences or talks that I went to. The physicians have to find a therapist that they cannot outsmart. So we're very skilled at navigating conversations. We know what to say to pivot a conversation, but we need somebody that's going to challenge us and help us. And it took me a while to find that, but I have found that, thankfully. But it is very helpful. But there's still a stigma out there that I don't need this. I'm fine. I'm not allowed to need that. I should be fine. I should be strong. I should be stoic about it and keep moving forward.
It's that support, I think, that works for you. And we touched on it with you, Jamie. Like, did you reach out to people? Were you able to speak to people? And we've spoken about that. But it's actually, what else, through my professional career, it was mentors, and they always started as professional, but they ended up being personal. It was, oh, how do I navigate my, climb through this company, and actually it came down to, how do I respond to this? What is challenging me? What is burdening me? And it's, you know, therapy as well, or coaches, or, you know, it's encouraging people to actually take, you know, it's okay to ask for help. It's okay not to have all the answers. It's okay to struggle.
Yeah, I'm just going to add something, if that's all right, because I think the other thing is that a lot of people get stressed out because they really see how the system is, and which is different from the expectations of what the system should be like. We've already mentioned how complicated organizations are. And actually, another way to reframe things is actually to say, well, you know what, the situation is what it is. The NHS is what it is. The healthcare systems in the US are what they are. Nothing is changing. And for me to be more fulfilled, for me to be happier and purposeful and passionate about what I do on a day-to-day basis, what can I do for myself to allow me to lead that life that I want to lead? And that's one of the hallmarks of what we're trying to promote with my company, and the services that we're trying to provide, is really to say, you know what, where you are now is not through chance. It's because you've made these micro decisions on a day-to-day basis to lead you to where you are now. Where do you want to be in, say, 3 to 5 years time? And what have you tried already to try and get you there? Because most people know where they want to be. Most people know where the stresses are. And it just happens to be they haven't found that right pathway. And this is where the coaches come in, because you say to yourself, okay, well, this is where you want to be in 3 to 5 years time. If you are where you want to be, how would you feel? How would that make you feel? Yes, it would make you feel great. It would make you feel more energized and happier generally day to day. Okay, fine. Well, what can we do now to get you onto that pathway to get you to where you want to be? So it's very interesting, because actually nothing is, I mean, for example, I'm now living 3 years on beyond burnout on the opposite ends of the spectrum. I'm really fulfilled. I'm really passionate about what I do. And nothing has changed, really. If you think about it, my finance, I haven't all of a sudden become a multi-millionaire overnight. The NHS is still the NHS. That hasn't changed either. I still work with the same colleagues. I still have the same job. Yet I feel grateful for where I am at the moment. And I've got this passion that I've now tapped into, some of which is in the NHS. I managed to disconnect more from the stuff which was stressing me within the NHS, but I've got this renewed sense of passion outside the NHS, and that's giving me that energy. And everyone can do that. We're all the great thing about it is that we're all different. We all have different things that light us up. We've all got different hobbies and interests and everything else. Penny and Jenny and Dhaval, what you're interested in and passionate about, I might not be, and vice versa. Okay, it's about finding, what are you passionate about? Yes, you could have passion within the career, but what are you passionate outside your career? And what can you, and then it's about, well, okay, well, how can I leverage my time in a way that's going to feed into that passion? And once you start doing that, that's where the breakthroughs really happen.
So
I would agree with that. I'm sorry, I would agree with that, because I think if you ask yourself, I would ask Jamie, if you asked yourself 15 years ago, would you be in this position doing this? I think probably I'm going to answer for you. I don't know if the answer would be yes, right? It would probably be no. I would have never thought I'd be doing this either, but I'm glad I am. And I think you're right, to the point, we get to a point where we have to find that one thing that's going to keep us going, whether it's associated with medicine or not, and we have to do it. Otherwise, we define ourselves too much by our career.
Correct.
In our employer, for better or worse, defines us. And that is a recipe for disaster, because I've gone through it myself.
Absolutely. And just to add also, Dhaval, just to add from what you say, so I completely agree with what you say, but just to add, it would really great for people to have that passion, bit of passion within medicine, but also a passion outside, because one
100%.
day you're not going to be working as a doctor. You know, you never know what's going to happen.
Right.
You could have a health issue or something like that. And if you've got no passion outside medicine, if you stop doing it for whatever reason, then you have to have something there. How many colleagues? I don't know. I'm interested to hear what you say about this, Dhaval. How many colleagues do you know that have retired and all they did up to that point was just medicine, doctor? They retire. They've got no purpose in their lives. 2 years later, they're dead.
Yeah, that happens, and the opposite happens where they're scared to retire and they practice to a point where they should not be practicing.
Right.
So all of the above.
Yeah.
I think, before we sort of come to a close today, I would like to ask both of you really, what changes or innovations give you hope that Doctor Advocacy is going in the right direction and is going to become more effective and widespread? Is it these discussions that we're talking about, that you're talking to colleagues, telling them to do more of what, makes them feel good? Is it, you've mentioned, Jamie, as well, about finances being really important, learning skills that potentially you haven't learned going into medicine in the first place? I'd be curious.
I'm optimistic.
Yeah.
Oh, go ahead.
Go on, Dhaval.
Okay. I'm optimistic of the digital innovation with AI and how that, I'm not confident. I'm going to be a little bit negative. I'm not confident our system's going to change overnight, right? And in my career, next 15 years, I'm not confident we're going to see a lot of changes. What I am excited about is what innovations will be out there that are going to make my job administratively easier, in order to give me more time back at the bedside. It's not an easy overnight solution, but that's something that gives me a lot of hope, especially with ambient listening, AI, and used in a way that's beneficial to us. I think that's a very powerful way to give back time to us, which will give back time to the patients. And also, to your point, having these conversations and slowly changing the culture. I think it takes people like Jamie out there, hopefully myself too, that are there having these conversations, which is, slowly breaking down the barrier.
Yeah, I'm actually really surprised that AI isn't playing a greater role in some ways, because Jamie, you're still talking about, bureaucracy and, paperwork. Is that down to
They
data
can't get through, they
collection
can't get
system?
into the change process. They can't embed it in the
But they don't
system.
want to pay for it.
Well, I don't know. I mean, listen, the fact of the matter is none of us know what the impact of AI is actually going to be. I've got my own thoughts. Those thoughts could be very, very off key. I don't know what's going to happen. There is potential benefit. I mean, first of all, we talked about the admin burden. Okay, so AI can actually help with that. And I think there's a big drive in the NHS to try, and I think there's recognition that the high admin burden is actually really having a negative connotation to the actual role. So that's one thing. But one thing I would say is that, when you look working in an organization, you're kind of like within this vehicle where you can't really go above and beyond. It's kind of almost like a bit like a factory, if you like. You're in this factory and you're there, you're paid for your time to give your expertise, but it's not going to reward you if you're going to go above and beyond and be creative. And what we're seeing now, and it's interesting because it's not just medicine, the world has changed, hasn't it? So we're coming out from the industrial age into this new digital age where everyone's got access to social media and AI tools and all sorts of things. And it seems to me that very much today's world is very much more about entrepreneurship and problem solving and how we can leverage AI to solve the most meaningful problems. And if you think about it, if we're working within an organization that doesn't allow us that creativity, then we're not going to be able to take advantage of the resources and the tools that are out there to really make an impact and to put our unique experience and insight into that thing. And what I love about what Dhaval's doing and what other people are doing, you hear about other doctors, for example, doing portfolio careers, is that they get an opportunity to really have that balance between their primary doctor role, which I think is going to change because I think a lot of it's going to be more about communication skills and relationships with patients, because we've got tech to do a lot of the other stuff. But also, in addition to that, how can we start maybe diversing ourselves individually, in addition to being that primary doctor, also to be problem solvers? And how can we use the resources that we have, the tech, the AI, etc., to really add value above and beyond our primary role to solve medical related problems and other problems for that matter?
Right, so that leaves us now with our tween question. And that question posed was, what do doctors do when they make mistakes? And I'd like to go to Dhaval first, please.
It's a good question. Very good question. First and foremost, it has evolved for me from my career. When I first became an attending and I made a mistake, I would be very hard on myself to the point where it was near This really catastrophic. I couldn't sleep. There was a lot of defense, and it was a very bad sort of dark cloud that followed me. As I evolved into more of a leadership role where I saw more people doing things that not necessarily harmful to the patient, but was a mistake or an oversight, I realized that my motto and my approach is quite different, that, we are all going to make mistakes. The sad part is doctors are trained not to make mistakes because that's the way we are trained historically. So we're not knowing how to make mistakes, and we need to know how to lose the race sometimes, and stuff will happen. And to be mindful of that second victim syndrome, that look, when we make a mistake, we feel it in our heart just as much as anybody else, and we need to look for support and help each other. And fundamentally acknowledge you make the mistake, be open about it, be openly communicating, talk to your peer, a trusted peer and leader about your mistake. And I'm always an advocate if it's something that needs to be disclosed. A lot of times it is something that needs to be disclosed to the patient. Disclose it openly, say this was an oversight, this is what happened, this is what we're doing to change it, no harm was done, or this is potential harm and we're going to monitor you for it. I think that's the best way to approach it, and go in knowing that it will happen. It happens to all of us, and it's okay to make mistakes. And I'm saying that so freely and easily, but trust me, it's been a process for me to adapt my mindset to that.
And learning from those mistakes, absolutely.
Oh, of course.
Yeah. And Jamie, for you?
Yeah, so it's a really great question, and I have to say, when you posed that question just now, I think to myself, "Oh my God, what am I going to say?" The fact of the matter is I suppose it depends on the severity of the mistake, number one. Okay, so if it's a really, really serious thing, the system's going to pick it up. And yes, of course, the thing that's going to be immediately is, first of all, is the patient okay? Because that's the most important thing. Are they safe? Assuming the patient is okay, it's going to be you're very much in the hands of the system. And then, is the system going to support me? Am I going to come to harm with it? Am I going to be in front of the coroner? Am I going to be in front of the general medical counsel? Is this going to go illegal? I'm going to be honest with you, these are the thoughts that are going through her head. And obviously it depends on the severity of the mistake, but for those serious mistakes, that is what's going to happen. You feel ashamed, you feel guilty. All of those sort of emotions that Dhaval was talking about do go through your mind. What really is absolutely crucial is to make sure that there is that, as Dhaval said, that trusted colleague that is going to be able to support you, without judgment, and really sort of support you through that. Because I think without that, the system is such that the default when a mistake is made is that something's wrong, something has to happen. And the fear that a lot of doctors face, very well documented, for example, is the Bauer-Garber case. I don't know if you've heard of that case before, but that is, without going into too much detail, there was a mistake that a doctor made. It went on their appraisal records as a self-reflection exercise. That's supposed to be a confidential two-way process. That ended up with the GMC, and that doctor was pulled up by the GMC. So there has to, first of all, the system has to be able to allow honesty and openness, that when a mistake happens, there won't be that repercussion for the doctor. I don't think anyone goes out of their way to make a mistake. A mistake's a mistake. But in terms of what doctors do when they make mistakes, the first thing that I would do, first of all, make sure the patient's okay. And secondly, who is that most trusted, supportive colleague that's going to help you through this?
And you all make mistakes, and there can be a solution, right? You can work through something in most cases and find, then, move forward, I think.
Well, you have to recognize as well is that mistakes and failure and things like that are actually a great opportunity to learn. So if we're putting too much of a negative connotation on it, that actually mistakes are awful and doctors need to make mistakes at all costs, well, first of all, that's not realistic. And secondly, you're actually reducing the opportunity to grow and develop and make the system safer.
A good saying I was senior, to close out, if I may, a senior physician once told me is that, no, I don't know more than you. I've just made more mistakes than you.
Right.
And therefore I've learned more than you.
Yeah,
exactly.
Right. Yeah, spot on.
Thank you so much for joining us today on this episode of Perspectives. We hope our conversation with Dhaval and Jamie has shed some light on the many layers of advocacy within medicine, for patients, for doctors, and for the healthcare system as a whole. If you're a healthcare professional, we hope you feel seen and supported. And if you're a patient or simply curious, we hope this episode helps you better understand the incredible challenges and responsibilities doctors face every day. Remember, advocacy isn't just about big gestures, it's about listening, empathy, and sometimes the small but powerful acts of care that build better communities and healthier futures. If this episode resonated with you, please subscribe, share it with someone who might find it helpful, and leave us a review to help others find perspectives. We'll be continuing this conversation in a few weeks' time, so stay tuned for more. In the meantime, take care of yourself and each other, and until the next time, keep informing those perspectives.